Every second, your heart is working, pumping blood to every part of your body. But what happens when its own blood supply suddenly stops? The heart is a muscle, and like every living muscle, it needs oxygen. That oxygen comes through the coronary arteries.
Two main coronary arteries supply the heart.
Left main coronary artery and right coronary artery.
The left coronary artery quickly divides into major branches, including the LAD and circumflex artery. These vessels carry oxygen-rich blood to the myocardium. When coronary blood flow falls, the heart muscle begins to suffer.
One major cause is atherosclerosis. Over time, fatty material can build inside the artery wall. The channel becomes narrower. But narrowing is not always the final event. A plaque can suddenly rupture or erode, and this can trigger clot formation.
Platelets become activated. They stick together and recruit more platelets. A thrombus begins to grow. The clot can partially or completely block the artery. Blood can no longer reach the myocardium normally. Now, the clock starts.
The myocardium becomes ischemic. Ischemia means the tissue is not receiving enough oxygen. At first, the damage may still be reversible. But if ischemia continues, myocardial cells begin to suffer irreversible injury. This is where infarction begins. Myocardial infarction means death of heart muscle, caused by prolonged ischemia. In simple words, heart muscle is dying because blood cannot reach it. But scientifically, myocardial infarction is more than just a blocked artery. It means acute myocardial injury with evidence of acute myocardial ischemia. The most common mechanism is called type 1 myocardial infarction. Usually, an atherosclerotic plaque ruptures or erodes, and a thrombus blocks the coronary artery. This is why one phrase matters in cardiology. Time is muscle. The faster blood flow is restored, the more heart muscle can be saved. But not every heart attack looks the same. Some produce ST elevation, while others do not. So how do doctors know which type of heart attack is happening? And why can the same disease produce very different symptoms? A heart attack does not always look the same. Doctors divide acute coronary syndromes into different clinical patterns. The most important are STEMI, NSTEMI, and unstable angina. First, STEMI. STEMI means ST elevation myocardial infarction. It usually involves an acutely blocked coronary artery. When the artery becomes suddenly blocked, oxygen delivery to part of the heart falls sharply. This produces acute myocardial ischemia and injury. Now, consider NSTEMI. It means non-ST elevation myocardial infarction. There is myocardial infarction, but no persistent ST elevation on the ECG. So what is the key difference? STEMI is identified by the clinical picture and characteristic persistent ST elevation, while NSTEMI has myocardial infarction without persistent ST elevation. But there is another crucial clue: troponin. When heart muscle is injured, cardiac troponin can enter the blood. High-sensitivity troponin is the preferred biomarker for myocardial injury. Then there is unstable angina. It is also part of acute coronary syndrome, but it is not a myocardial infarction. Why? Because there is no evidence of acute myocardial injury of infarction. Troponin does not show the diagnostic rise and fall of acute myocardial injury required for MI. Together, STEMI, NSTEMI, and unstable angina form the clinical spectrum of acute coronary syndrome. They all involve acute coronary ischemia. But the ECG, biomarkers, and clinical findings help doctors distinguish them. But why does this happen in some people? The risk increases with age, smoking, hypertension, and diabetes. High LDL cholesterol is another major risk factor.
Obesity and physical inactivity also increase cardiovascular risk. An unhealthy diet can contribute to high cholesterol and metabolic disease.
Family history and chronic kidney disease can also increase risk. The classic symptom is chest discomfort. It may feel like pressure, heaviness, tightness, or squeezing. The discomfort and pain may last several minutes or come and go. The chest pain can spread to the arm, shoulder, jaw, neck, or back. But not every patient has classic chest pain. Shortness of breath and sweating are also common. Nausea, dizziness, and weakness may also occur.
Older adults and people with diabetes may have less typical symptoms. Some patients may mainly feel breathless, weak, nauseated, or unusually tired.
So when a patient arrives with possible acute coronary syndrome, doctors cannot rely on symptoms alone. They need an ECG, cardiac troponin, and rapid clinical assessment. The symptoms tell us something is wrong. But the ECG and blood tests can tell us what is happening inside the heart. When a patient arrives with suspected acute coronary syndrome, one of the first and most important tests is an ECG. It records the electrical activity of the heart. A 12-lead ECG looks at the heart from different electrical viewpoints. Together, these leads help doctors identify patterns of myocardial ischemia or injury. And in STEMI, every minute matters. In suspected ACS, the ECG should be obtained and interpreted rapidly, with a target of about 10 minutes from first medical contact. This can reveal a STEMI that needs immediate reperfusion.
Activate the cardiac team now.
In STEMI, the ECG may show significant ST segment elevation in leads representing the affected region of the heart. This suggests acute coronary occlusion in the right clinical setting. An ECG is more than a line on a monitor. It is a window into the electrical behavior of the injured heart. But an ECG alone cannot diagnose every myocardial infarction. This is especially important in NSTEMI. The ECG may show ST depression or T-wave inversion, but it can also be non-diagnostic, so doctors need another piece of evidence. That evidence often comes from cardiac troponin. Troponin is a protein associated with heart muscle cells. When myocardial cells are injured, cardiac troponin can be released into the bloodstream. High-sensitivity troponin is now the preferred biomarker for myocardial injury. But one troponin result does not always tell the whole story. Doctors may repeat the test after a defined interval. They look for a rise or fall in troponin. But remember, an elevated troponin does not automatically mean a heart attack. Troponin can rise whenever the heart muscle is injured. Doctors need evidence of acute ischemia to diagnose myocardial infarction. Sometimes doctors also look directly at how the heart is moving. This is echocardiography, or an ultrasound of the heart. It can reveal regional wall motion abnormalities. Echocardiography can also assess ventricular function. It can help estimate how well the heart is pumping and identify some mechanical complications of an infarction.
But sometimes doctors need to see the coronary arteries themselves. That is where coronary angiography becomes important.
A catheter is guided through an artery toward the heart. Contrast dye makes the coronary arteries visible on X-ray. Doctors can identify the location and severity of a blockage. And in the same setting, the artery may be opened with PCI. So diagnosing a heart attack is like putting together a medical puzzle. Symptoms give the story. ECG shows electrical changes. Troponin shows myocardial injury.
These detailed images help pinpoint the exact location of any blockages, and angiography can reveal the coronary artery problem.
Now the diagnosis is made, but diagnosis is only the beginning. The next question is the one that can save heart muscle. How fast can we restore blood flow?
Once a heart attack is suspected, time becomes critical. Every minute of ongoing coronary blockage can mean more myocardial damage.
The goal is simple: restore blood flow as quickly as possible. One of the first medicines used in suspected ACS is aspirin. A loading dose is usually 162 to 325 milligrams, chewed. Aspirin reduces platelet activation and helps prevent further clot growth. Remember the clot we saw earlier? Platelets are major players in its formation, so blocking platelet activation is a major part of ACS treatment. A second antiplatelet medicine may also be given. These medicines include clopidogrel and ticagrelor. They block another pathway of platelet activation. When indicated, aspirin and a P2Y12 inhibitor are used together. This is called dual antiplatelet therapy. The exact drug depends on the clinical situation and treatment strategy. Antiplatelet therapy is not the whole story.
Anticoagulants can also be used in ACS when indicated. Examples include unfractionated heparin and enoxaparin. What about the chest pain? Sublingual nitroglycerin can relieve ischemic chest discomfort in appropriate patients.
A common dose is 0.4 milligrams. But nitroglycerin is not safe for every patient. It should be avoided with significant hypotension. And in certain patients with right ventricular infarction or recent PDE5 inhibitor use. And oxygen has an important rule.
It is not routinely given to every patient with myocardial infarction. It is used when clinically significant hypoxemia or respiratory distress is present. Severe pain can sometimes require opioid analgesia. Morphine may be considered when pain remains severe despite appropriate treatment. But it is not routine treatment for every heart attack. Another important medicine is a high-intensity statin.
For example, atorvastatin 80 milligrams once daily. Statins lower LDL cholesterol and help stabilize atherosclerotic plaques, but medicines alone may not be enough. In STEMI, the blocked artery often needs urgent reperfusion. The preferred method, when available in time, is primary PCI. PCI means percutaneous coronary intervention. A catheter is guided into the coronary artery, so the blockage can be treated and blood flow restored.
A balloon can open the narrowed segment, and a stent can help keep the artery open. Blood flow can then return through the treated vessel.
This is why reperfusion has strict time targets. For a direct PCI pathway, the goal is rapid treatment, commonly within 90 minutes from first medical contact to device therapy.
If transfer is needed, the system aims to keep the total time within about 120 minutes. But what if timely PCI cannot be achieved? Fibrinolysis must also be given rapidly. In selected STEMI patients, fibrinolysis may be used. Its goal is to dissolve the thrombus and restore coronary blood flow.
The classic hospital target is door to needle within 30 minutes. But fibrinolysis is only for carefully selected STEMI patients.
So the decision is not simply about giving a drug. It is about choosing the fastest, safe way to restore blood flow. Because in myocardial infarction, time is muscle.
But fibrinolysis is not harmless. Before giving it, one question must always be asked. Could this treatment cause catastrophic bleeding? Fibrinolysis can save heart muscle. But it can also cause serious bleeding. So patient selection is critical. One major absolute contraindication is any previous intracranial hemorrhage. That means fibrinolysis can be dangerously unsafe because it can increase the risk of catastrophic intracranial bleeding. Another absolute contraindication is a known structural cerebral vascular lesion. For example, a known cerebral arteriovenous malformation. The bleeding risk may be unacceptable. One major, a known malignant intracranial neoplasm, is another major contraindication. That means fibrinolysis can be dangerously unsafe. The concern, again, is severe intracranial bleeding. The safest treatment pathway must be chosen instead. A recent ischemic stroke is also an important absolute contraindication. For STEMI fibrinolysis, ischemic stroke within the previous 3 months is generally considered an absolute contraindication. Suspected aortic dissection is another absolute contraindication. The patient should be assessed for an alternative reperfusion strategy. A fibrinolytic could turn a dangerous tear into catastrophic bleeding. This is why diagnosis must come before treatment whenever clinically possible.
Active bleeding or a significant bleeding disorder is another major contraindication. The exception is normal menstruation, which is not considered active pathological bleeding. The risk of uncontrolled hemorrhage must always be considered. Significant recent closed head or facial trauma is another contraindication. Recent major trauma can increase the risk of intracranial bleeding. The history must be checked before fibrinolysis. When fibrinolysis is appropriate, several medicines can be used. Common agents include tenecteplase, alteplase, and retaplase. Tenecteplase is commonly used because it can be given as a single intravenous bolus. The dose depends on the patient's body weight. It promotes conversion of plasminogen to plasmin, which breaks down fibrin within the thrombus. As the clot breaks down, blood can begin flowing again. But giving fibrinolysis does not mean the emergency is over. The patient needs close monitoring for reperfusion, bleeding, and recurrent ischemia, and failed reperfusion requires urgent action.
If fibrinolysis fails, rescue PCI may be required. The coronary artery is reassessed with angiography. The blocked vessel is then treated mechanically.
Even after reperfusion, myocardial infarction can cause serious complications. Some are electrical, and others are mechanical.
Ventricular tachycardia and ventricular fibrillation can occur after myocardial infarction. These rhythms can rapidly become life-threatening.
That is why continuous cardiac monitoring is essential. A large infarction can severely reduce the heart's pumping ability.
When the heart cannot maintain adequate circulation, cardiogenic shock can develop. This is a medical emergency requiring intensive treatment.
Mechanical complications can also occur after a large infarction. These include ventricular septal rupture, papillary muscle rupture, and free wall rupture.
Echocardiography can help identify these problems. So what have we learned? Recognize the symptoms, obtain the ECG, confirm myocardial injury, and restore blood flow rapidly. Because when the heart is losing blood, every second matters. A myocardial infarction begins with a blocked artery. But the outcome depends on how quickly we recognize it, treat it, and restore the heart's blood supply.
If you really like this way of learning, then tell me what topic you want to learn next. Comment your next topic below.
This is MedHelp 101, where we make the invisible visible. Thank you for watching.